Hello, everybody. Thank you so much for joining us for the next session on this session is going to be on top papers in antimicrobial stewardship 2022 and 2023. It's my privilege to be introducing two very good resource person. And to start off with, Dr. Tim Gauthier. He earned his PharmD from Northeastern University, Boston. He then completed his PGY1 pharmacy practice residency and PGY2 ID residency at Jackson Memorial Hospital, Florida. He has worn different hats in pharmacy career, starting off as an academician, practiced clinical pharmacy after that. His current role is a leadership role at Baptist Health South Florida, with primary focus and again more research into advancing infectious diseases pharmacy and antimicrobial stewardship. He's a very passionate content creator and an editor in chief of ID Stewardship and Learn Antibiotics. Dr. Tim has over 40 review articles, co-authored several book chapters, published book, and written hundreds of blog posts. He is a peer reviewer for several medical journals and health profession societies. He was the 2019 recipient of the Society of Infectious Diseases Pharmacist Geeta Patel Best Practice Recognition Award. He's been listed amongst the top 100 Twitter influencers in infectious diseases in 2022 and the most influential pharmacy leaders in 2021. Again, it's he has a lot of very useful content in ID stewardship and learn antibiotics, and these pages have gone over a million, almost more than 5.5 million page views by the end of 2023. If you still haven't followed him at his social medias, please do, because I've been following him for quite some years, and personally these are really good contents. You could get updates and a lot of information is available in his websites. Please do visit if you haven't. And on a personal note, I was able to meet him during the ID week last year at Boston. Such a humble personality, and I could see the passion he has for stewardship and infectious diseases pharmacy. Such a honor for us to have him for this session. Thank you, Tim. So, and the next speaker would be Thomas Leo, who's obtained his PharmD degree from University of Florida, then completed his PGY1 pharmacy practice residency, and currently he is doing his PGY2 infectious diseases residency at Baptist Health South Florida Clinical Pharmacy Enterprise. His interest includes antimicrobial stewardship, gram-negative bacteria drug resistance, and antifungal infections. Thank you, Thomas, as well. Over to you guys.
Thank you so much for that warm introduction. And I just want to say it's really a pleasure to be here today. This is something I've been looking forward to since we first discussed this opportunity. And so to have the opportunity to come here and talk about this topic, which is something I'm very, very passionate about, genuinely, and just enjoy. I hope we can share some good information, some good resources, and have some discussion about how to apply some of these concepts to practice in 2024. I want to also thank my co-presenter, Dr. Liu, for being here on the call as well, and helping with this presentation. So just advance, there we go. In terms of disclosures, everything that I'm saying is my own opinion and doesn't necessarily reflect my previous employer, current employer, or any future potential employer's policy or position on the content that we're discussing today. I also want to note that this was created on my own personal time, on my own personal computer. So this is an activity done completely on my own time and resources. And next slide here. So in terms of just a little bit about me, I know we just had an introduction, but I do have the pleasure of serving as a leader for a 12 hospital system with 100 plus outpatient centers. And I think that's relevant to the talk a little bit because you'll notice that my interests lie with that content area. There's a lot more to stewardship than just acute care and ambulatory care. You have a lot of transitions of care and other areas within the landscape of healthcare. But I focus mainly on the hospital system and mainly on adults with some sprinkling of, urgent care and that type of environment. And then I wanted to highlight just that I'm a really big advocate for infectious diseases and the role of the clinical pharmacist in infectious diseases. And that's really my goal on social media is to promote the information about that topic, to share relevant articles about clinical pharmacy, what's evolving in infectious diseases space. And it's really a pleasure to interact with people and meet people and connect people through social media. You don't have to go on social media and start an account and start tweeting and interacting and sharing, but I really highly encourage you to look to tools like Twitter or X, as now it's called, as a way to keep pace with what's going on in the literature, to kind of see what some of the leading experts are talking about. And it's just a very valuable tool that you don't necessarily have to actively engage in. And in our profession of pharmacy, we tend to be more of a lurker than an active engager, and that's totally fine. But I wanted to encourage people to utilize that as a tool because you can find a lot of really great resources and also connect and make relationships with people from all around the world, which is just amazing. And then Thomas, Dr. Liu will be graduating in July, or yeah, July from the program here. And we look forward to seeing which direction he goes in with his residency. He's within a large 12 hospital system. So I wanted to take a moment to highlight some of the activities that I do have been doing over the last several years. It's actually been coming up on 10 years almost, which is incredible. The Learn Antibiotics book I published about a year ago and actually has been going all over the world. It's been a really amazing experience. And it's so difficult to learn infectious diseases and about antibiotics. And so I hope that book can be a supplemental resource that's different from other resources, because the more ways we can approach a problem and look at a problem from different perspectives, we're going to have a better idea of how to crack that nut. So that's kind of the goal of that book. And it can be helpful for people that are practicing or in, students going through their rotations and whatnot. Now, learnantibiotics.com is an expansion of that, and there's a number of different areas of interest. And if you're a member or you're interested in this topic, feel free to reach out to me, ask questions. A lot of members have said, hey, this would be a great resource, and then we develop resources that are directed towards those members. So that's something I'm always looking forward to. Yeah. Then finally, the website idstewardship.com. It has some article sections that you might be interested in. Pharmacy residency, infectious diseases, and antimicrobial stewardship are two of the sections. Reality check is like, if what is it like to be a critical care pharmacist? What is it like to be an infectious diseases pharmacist? What is it like to be an infectious diseases pharmacy resident? So trying to share insights about what is it like to be a pharmacist in a different space. Healthcare at large is a kind of a general hodgepodge section. So those are some of the things you can find. And actually, the website gets about 125,000 people visited every 6 months. So it's really cool to be able to reach so many people and have an international audience that I really had never thought about. But now I understand there's a lot of value to sharing information in an open access way, which we do on idstewardship.com. So now I'm going to move into the objectives of the lecture today, which are to discuss characteristics of important contemporary publications in the field of antimicrobial stewardship, which is the best field, and then also analyze external validity of recent stewardship publications. So it's always important to just, stop on your definitions here and what is antimicrobial stewardship, and which is the effort to measure and improve how antimicrobials are prescribed by clinicians and used by patients. I always refer to it as the safe and appropriate use of antimicrobials, but this is a very nice, concise definition that's provided by the CDC as well. As you're thinking about antimicrobial stewardship, if you're an advanced steward or you're a beginner steward, the CDC core elements should be a go-to resource on all things antimicrobial stewardship activities. So I wanted to call that out. And there are core elements that apply to the hospital setting as well as other settings. There are also a number of guidelines on antimicrobial stewardship, for example, from the Infectious Diseases Society of America and Society for Healthcare Epidemiology of America, SHEA, as well as society guidelines that exist from various other government organizations and regulatory bodies. So here in the United States, we have the Joint Commission and the CMS, the Center for Medicaid and Medicare Services, that have regulations related to antimicrobial stewardship. And many times, as we're approaching what to do at our sites, we want to think about regulatory wise, how do we adhere to the requirements of the regulators, but also improve patient care at the same time. So it really is important to kind of observe these core elements, national guidelines, and regulations in the context of what data is out there and what can I do for my patient population. Now, as you look at the SHEA and IDSA guidelines from 2016, which was the most recently published guideline, there were zero high quality evidence recommendations. So when you look at the data in the field of antimicrobial stewardship, a lot of these studies that we see are observational, so they're retrospective, they're not randomized controlled trials, and it's an area where we need more information. So throughout this talk, I hope we can encourage you to think about what you're doing and consider publishing your work so you can share with the growing body of knowledge in this space. And of course, keep calm and do antimicrobial stewardship. Now, another big component of antimicrobial stewardship in practice is variability. So you could be at a 200-bed hospital in one state and then move to a 200-bed hospital in another state, and it could be completely different. And your approach to stewardship should align with the needs and goals of the institution and organization. And those needs and goals can also change over time, even at that one specific organization. And I'm sure many people that are watching this will relate to what I'm saying. Now, your population at one site may be older individuals who are at risk for certain types of infections or may have a lot of challenges with acute kidney injury, for example, or renal dosing. You could have a burn population or a trauma population or an immunocompromised patient population that totally changes the level of importance for different issues within your site. The physical space and just geography of how you access things. If you are able to move an antibiotic quickly through your hospital, or it takes time to get from point A to point B, those logistics and workflows have a huge impact on what stewardship activities you can functionally do and services that you can then provide through your stewardship program. The organisms that you're targeting may vary. The resistance patterns, of course, can also vary significantly if we're talking about from country to country. If it's more gram negatives and which type of resistance gram negatives versus gram positives, or is it a fungi type of issue that you're seeing that you want to address? Workforce expertise is a huge variable factor. There aren't a ton of infectious diseases trained pharmacists out there, and many infectious diseases pharmacists actually leave clinical pharmacy to move into a clinical coordinator position, administrative roles. And there aren't that many training programs. I believe there's about 120 to 130 training programs in residency or fellowship for pharmacists and infectious diseases. And so there just aren't, there's a supply and demand delta that's just not going to get there. And what you have available at your site, you have to be realistic with. So if you have a very ambitious, highly capable workforce that is going to hard charge and go out there and do things, you can, pick one initiative. But if you have a workforce that maybe is challenged by a number of other demands that maybe is less hard charging and has a different perspective, and has a different set of expertise, you may not be able to do the same things. And you may want to choose an alternative strategy for your stewardship program. And then, of course, your organizational priorities. What do your leaders care about? Is it surgical site infections, C. diff? Well, of course, they care about everything, and everything is important. But what are the highest priorities at that time? So again, as you look at the literature, as you consider what you can do locally, you have to consider the variability and how does that impact the external validity of the studies that you're discussing or considering. And we could talk about variability for a long time here, of course, with antimicrobial stewardship, but it's just so important. It is the name of the game. So as I started to consider the topic of covering some of the important publications in antibiotic and antimicrobial stewardship in the last year or two, I went to PubMed to see how many articles had been published on the topic and used the search term antibiotic stewardship or antimicrobial stewardship. It resulted in over 12,000 hits since the term was first seen in the literature back in about 1997, with a peak in 2022 of almost 2,000 articles. So recently, in the last couple of years, we've definitely seen an explosion in the interest in academic literature with antimicrobial stewardship, and we have a lot to choose from, which is a great thing. Now, how do you find the best pubs when you have over 1,000 articles to look through? Well, there's no good answer. So I'm going to tell you what I did and some of my thoughts. One way that I've done this in the past is to look through top journals and use key terms within those journals or within PubMed to search in New England Journal of Medicine or JAMA or other journals and see, what have they published about antimicrobial stewardship within the timeline I'm looking for. And there are a lot of really good journals now with lots of publications in this space. So infection control and hospital epidemiology, ICHE, has been a real great leader in the space of antimicrobial stewardship over the years. But open forum infectious diseases, antimicrobial stewardship, and healthcare epidemiology, these are some other really great journals that are publishing a lot in this space and really deserve a lot of recognition for getting more information out there about what we can do and disseminating knowledge on the topic of stewardship. Another way to address it would be to review which publications have the most citations using Google Scholar. So if you go to Google Scholar, you can put in a publication and it'll tell you how many citations it has. Unfortunately, though, we're trying to look at the most current publications, so the timeline doesn't really work for this. If I was doing a review of articles of the last 10 years, this might work, but this strategy is not a great strategy for the last, year or two. And then the other way to do it, which is my gut instinct way to find the best articles, is to try to remember what happened on Twitter in the last year or two, or now X. It's just way too much to recall. Every day is just a whirlwind of content, although it is a lot easier to weed through using Twitter. Um, but that is one way to try to identify some of the more relevant articles that maybe got the most discussion, and I find that to be, again, very valuable. So shout out to AB Steward on Twitter. He publishes a lot of tweets and posts on new articles that are emerging and coming out. So I think he's a fantastic person to follow, and he's out of Saudi Arabia. Someday I hope to meet in person because we've had a relationship for several years now. And then also SIDP Farm, which is the Society of Infectious Diseases pharmacists. They do a really good job putting out content on new articles. And also just give a quick shout out to their podcast called Breakpoints, which is a really amazing podcast and does periodically cover new articles that are emerging in the literature. So all that considered, I decided to go with the option of using some publications and some work done by some colleagues that I was able to participate in several times. And upon first view, you might think that that's like gram-positive cocci in clusters or something like that, but it is actually bread. There are loaves of bread, and I apologize if you can hear the bird screeching outside. I can't control that. And that is a baker's dozen. If you're not familiar with the term baker's dozen, it just means 13. So a dozen being 12, a baker's dozen being 13. And in 2016, well, it's really started in 2015, we set out to publish an article about the top antimicrobial stewardship papers in 2016. So we searched the literature and we came up with a summary, and I'll go through some of the methodology here. And that article actually got accepted to the Journal of Antimicrobial Stewardship, which was called JAMS. And then JAMS did not subsequently continue, which is very sad because that journal had a lot of potential and was super interesting. And maybe someday it'll be resurrected. But if you're looking for the 2016 version of this publication, it may be a little bit difficult to find. However, it can be found on one of these preprint servers. Now, in 2017, the topic was picked up by Open Forum Infectious Diseases, or OFID. And since then, we've had an annual publication. I'm not on all of them, but I've been engaged with several of them, which has been a real pleasure because the people that are on these teams are really outstanding and phenomenal. And I can't say more positive things about them. So since 2016, or since 2017, rather, these articles have been showing up in Open Forum Infectious Diseases. In 2021, it was actually broken down into non-hospital care versus hospitalized patients. So if you're just practicing in the non-hospital care arena, that might be something to note and be interested in. And I want to call out that these are all open access. So open forum infectious diseases is really great that all of their articles are open access, and you can see that the little lock, the orange picture there is unlocked. So they're accessible, they're easy to get to, and there's some of the best publications around in terms of the content that's covered within each of these articles for each year. And you can follow Surge on Twitter or X. Surge is the research group, the Southeastern Research Group Endeavor, I believe Surge stands for. They're the group that facilitates this publication happening. And shout out to Chris Bland as well as Brandon Bookstaver on their work with Surge 45. So the most recent article was published in Open Forum Infectious Diseases recently, just in January, and focuses on articles from 2022. 1,770 articles were identified, and that led to screening down to 179 articles. These articles were sent out for ranking by the Surge 45 group. This group is made up of infectious diseases professionals, primarily infectious diseases pharmacists, from what I gather. Um, those 179 articles were ranked by the Surge Network, and the top 13 ranking articles were included for the paper. 7 were from the hospital setting and 6 were from the non-hospital setting. So in 2020, in this most recent version of the publication, there was not a split hospital and non-hospital. They were both combined. So let's move into some of the work that was evaluated. First, we have evaluation of an opt-out protocol for antibiotic de-escalation in patients with suspected sepsis, a multi-center randomized controlled trial. And, right off the bat, I'm just excited to see something related to antimicrobial stewardship that's a randomized controlled trial. Again, from a study design perspective, many times what we see is observational retrospective data coming out, which is still good and swell, but RCT sounds fantastic. So sepsis is a really big deal in antimicrobial stewardship. One of the main reasons that patients are initiated on broad spectrum antibiotic therapy is sepsis, and antimicrobial stewardship in the emergency department, which a lot of those patients are going to have their first touch point there. That's a huge area for us to get the drug right at the time of sepsis coming into the hospital. Now, this RCT included a 23-item chart check in non-ICU patients with negative cultures. Now, they screened something like almost 10,000 patients, but only about 8% of those screened were able to be enrolled because they met the criteria. And what they looked at was days of therapy to see, did they reduce the days of therapy by having this kind of timeout implemented within patients who have sepsis but are not in the ICU and have negative cultures. And what they found was that this opt-out protocol led to more discontinuations, but the days of therapy, that primary endpoint, was similar when antibiotics were continued. So would an intervention like this at your site lead to a reduction in antibiotic consumption? Would it lead to a reduction in exposure of your patients receiving antibiotics? And you might consider things like, what is the average duration of antibiotics in a patient that comes to my site with sepsis? When someone comes with sepsis, how long is it until I have culture data back? What is my ability to perform a chart check, especially a 23-item type chart check on my patients? And maybe you have ways you can extend your capacity to do an advanced chart check. So using students and residents and learners might be an option. You might have pharmacists who need projects, or maybe medical students or medical fellows. And so kind of thinking outside the box is one way to solve that problem and make your program able to engage with something like this. But I think all things considered, sepsis is going to continue to be a major area of interest for antimicrobial stewardship. And when I think about sepsis, I can't help but think about this algorithm and this guidance that comes from the UK Health Security Agency. It's called the Start Smart Then Focus Antimicrobial Stewardship Toolkit for Inpatient Care Settings. And within the slide set, I put links on the bottom of the slides. You can also Google many of these, and the large majority of the content I'm covering today is open access. And they have an algorithm that could be applied and promoted within your practice. So number one is start smart. What is the evidence of the infection? Looking at their history, signs and symptoms, labs, etc. Making sure that evidence of suspicion of infection is really assessed and investigated. Once all that investigation happens, prescribing antibiotics, taking into consideration things like urgency, guidelines, allergies, and spectrum. And urgency, I think, is really an important part of this because does this person need to get antibiotics right now? Can we wait and get more information? And really tailoring the antimicrobial choices to that specific patient. Documenting your thoughts, that's really important, especially as a stewardship pharmacist. I'm looking at charts, so that documentation counts for quite a bit in terms of differentiating what infection type are we worried about here, and specifically not just the UTI, but is it an upper low UTI, a lower UTI? Are we talking about an abscess or UTI associated with bacteremia? So being specific in your documentation really helps communicate with the rest of the healthcare team. So very much encourage that. And then finally, focusing. So doing an antibiotic timeout within 48 to 72 hours. And I like the algorithm or the acronym they give, which is CARES, standing for cease, amend, refer, extend, or switch. And antimicrobial stewardship programs many times are kind of labeled as the police, and we really don't want to be labeled as people out there saying no to this and no to that. So I think the E there is really important, extend. And sometimes it is appropriate to extend antibiotics, and we don't want to get in the way or be seen as people that just want to stop the antibiotics all the time. Sometimes we do want to extend, so you might want to lean on that a little bit periodically to show that you're not just there to, quote unquote, police people. Now, and the next article looks at a comparison of active versus passive methods for responding to rapid diagnostic blood cultures. So you have a blood culture, and a rapid diagnostic is used to identify what the organism is and if there are resistance markers that are within that blood culture associated with that organism. It can be definitely a really high stakes area. So if someone has MRSA in their blood, you definitely want to get them on anti-MRSA therapy very quickly. And this was a retrospective observational study. It was looking at time to optimal therapy for gram-positive bacteremia. And they used three different groups. One was the control group, where the lab would call the nurse with the result, and then the nurse would call the physician. The second one was passive. So the same process would occur where the lab was calling the nurse. However, now the pharmacist team was getting a message to their inbox passively. And then the last one was with a pager. And in this third group, the pager would go off and there'd be kind of an immediate action. When they looked at the time to optimal therapy, they found the control group, that call from the lab to the nurse, it was 46 hours time to optimal therapy. Passive therapy was 42 hours, so a little bit faster by sending a message to the inbox. And active therapy was 23 hours. So the best time was with that active engagement and giving a pager to that pharmacist or that team member. There was no difference in mortality though. And so I think we do have to stop and think, hey, I want to make this intervention. I think it's good for our patients, but does it really improve care? And mortality, it's a hard marker, it's a good marker, and there may be other things to consider besides mortality. But I would really challenge you to stop and think before you hand someone a pager that they have to carry 24/7, 365. Really consider if what you're about to do to them with that pager is worth the outcomes that you're going to get from your patients. And sometimes the answer is, yeah, it's the right thing to do. And sometimes the answer is, no, it's not the right thing to do. And it's okay for that answer to also change over time. So maybe you say, you know what, we're not going to do this pager right now. In the future, we're going to try it. Or you say, we're going to try the pager. And then if it seems like we find another way to do this in the future, we can use data to guide our future decisions and discretions. Now, I wanted to call out this publication from Antimicrobial Stewardship and Healthcare Epidemiology, because burnout is a huge problem within our field of clinical pharmacy and within antimicrobial stewardship. And I think a lot of stewards can really relate to this, where when you sit there and you start to think about your task list, you just feel like there's so much to do and everything is a quote unquote problem. And how can you get to it all? So I think that a lot of us relate to, the "this is fine" meme. Now, the great thing is that we get to do really good work and there's so much impact that we can have, but it can be a level of burnout And personally, I have worked in a program that had an on-call phone, and it was not what I would describe as a positive experience. And outside of a very specific reason for implementing an on-call program, I would be very hesitant to try to bring this service to a stewardship program or to mandate this type of level of connection. You can do different strategies to mitigate it so it's not as much of a burden. For example, not having call between the hours of like 8 p.m. and 7 a.m. or something like that. So there are ways to be flexible. And I think flexibility and creativity is another key to success with an antimicrobial stewardship. But I just wanted to challenge you to think, will this service be something that we can deliver a measurable benefit on? And do I have the resources to commit to this? Because I don't want you to burn out your antimicrobial stewardship leaders. Now, as you consider that, you also just can't deny it. Antimicrobial stewardship plus rapid diagnostic testing is the best patient care. And you can see that from the data consistently over time with these publications. If we combine our stewardship programs and our knowledge and our connections and stewardship workers, right, bridging that gap between here's the information and getting it into the workflow and to the decision makers and making it action, make that action happen. That's where we get the best care. So I think we need to continue to encourage stewardship programs always being involved when we're doing rapid diagnostic testing. Okay, moving on to the next publication. This one was published in Open Forum Infectious Diseases and looked at an integrated infectious diseases and stewardship telehealth service focused on Staph aureus bacteremia, a Staph aureus bundle, adherence to that bundle, and then outcomes within 16 community hospitals. So not every hospital is going to have an infectious diseases pharmacist, maybe or an infectious diseases physician that's handy, right? But there's thousands and thousands of hospitals across the world. So how do we reach these hospitals? And telehealth has really emerged as an area of interest in order to get specialized resources to people who can benefit from those resources. So I expect that telehealth and telestewardship is really a topic we're going to see a lot more from in the coming years, as we are already starting to see that. And this was an observational study on SAB, which is Staph aureus bacteremia, with versus without the integrated infectious diseases telehealth services. They did not find a statistical difference in mortality or recurrence between the two arms, but they did find that patients had a reduced Staph aureus bacteremia-related readmission, so less readmission when the service was involved. However, they did have an increased length of stay. So this is promising work, and I think there is definitely a lot of potential in the area of telestewardship. I also want to call out that in a subgroup of the Staph aureus bacteremia patients with a controllable source, the telehealth services appeared to have a mortality benefit. And that's something that we see within antimicrobial stewardship literature is that once you dive down into a subgroup, you start to see where more value can be provided. So larger studies really help us to understand where the most benefit is. And this is an article that definitely kind of points us in a direction for telehealth and telestewardship. So now I'm going to pass it to Thomas, who's going to go over this article here.
Thank you so much. So this paper I'll be describing, this one is actually a prospective evaluation as well. It was an interrupted time series study, so a before and after, if you will. If you'll notice, Dr. Gauthier is also on this paper. It included about 8 hospitals in the Veterans Affairs or VA sites. They had 4 intervention sites, and then they picked 4 comparison or control sites of about the same hospital size, same ICU acuity, as well as academic teaching status, and then had them in different geographic locations, and so to avoid cross-contamination. And what they used was a 2-part intervention. So there was a case-based teaching that was typically implemented at the sites by a local champion. So that was either the infectious diseases physician or ID pharmacist, as well as an evidence-based algorithm that they used. And they delivered it to a multidisciplinary clinician team. So that included ED pharmacists, physicians, nurse practitioners, or mid-levels, as well as some other clinical nurses. And the 2 big outcomes that they really evaluated was ordering of urine cultures as well as antibiotic days of therapy. and length of time. And what this study found was that in the intervention groups, after the implementation of this education, there was a significant reduction in urine culture ordering, about equated to about 2,800 urine cultures that were not ordered as a result of that in the intervention groups, as well as a significant reduction in antibiotic days of therapy. I believe it was about 8,200 days of therapy. So I think that's really important, particularly in the space of asymptomatic bacteriuria, as if you're able to reduce the amount of bacteriuria that you're detecting, that would lead to the assumption of decreased prescribing for unnecessary treatment. And what this also showed was that targeted prescriber education, so having that internal facilitation is what this article referred to, was the most effective for curbing inappropriate asymptomatic bacteria treatment. But I think the most challenging aspect of this sort of personalized and continuous education is really sustainability. As there's a high turnover rate oftentimes in hospitals. And I think what's very challenging, particularly in settings like the emergency department or internal medicine areas, or urgent cares, is, those patients that come in not related for a urinary tract infection or any urinary symptoms. And then they just test a urinary analysis or urine culture in the very beginning. So that often leads to detection of bacteriuria and then inadvertent treatment of that. So I think that's where that education component really comes in, as well as some other clinical conundrums where a patient comes in with altered mental status, oftentimes the very elderly or frail patients, as well as those with external devices like Foley catheters, which are still often very challenging situations to deal with now. Next slide. Back to you.
Okay. So this article, TikTok, right, was looking at the time of antibiotic prophylaxis. So do we need 24 hours, 48 hours? Do we need to have antibiotic prophylaxis until the drain is removed when we're looking at neurosurgical patients? This is a retrospective design, included 9,000 cases approximately. And what they looked at was the incidence of C. difficile when we had prophylaxis given for 24 hours after the drain was placed versus until the drain was removed. And what they found was that the incidence of C. diff dropped from 0.5% in 90 days to 0.07% when limiting the duration to 24 hours. And they did not find a change in the post-procedural infection rates. I was really kind of struck by this result. I thought this was a very impactful and something that I would be interested in taking to my neurosurgeons, especially if there was a C. diff outbreak going on at my facility. I think this is also an example of where quality data can help you to then jump over and start a conversation with a physician or a care group that you might not otherwise be in discussion with. And you can use an article like this to trigger that conversation for starting. And as we kind of have those conversations, simple messages also help a lot. And so, for example, with antibiotics, more is often not better. And I think that is really the theme here. That could be the easy translatable message. Within antimicrobial stewardship, we do have a lot of challenges with our mouthful of words as we're trying to talk about all these organism names and these drugs that I even have a hard time pronouncing. So simple messaging combined with strategic connections and supported by data, supported by literature, those are keys to success for antimicrobial stewardship programs. Now, I believe Thomas will cover this one.
Okay, yeah, so this is another paper. It was also an interrupted time series analysis, focusing particularly on inappropriate prescribing of urinary tract infections in the emergency department. So this one was also a prospective quasi-experimental evaluation that was performed in North Carolina, United States. It was within 3 different hospitals containing ED sites, one being a large academic facility and 2 community hospitals. And what they did was they utilized a biphasic model. The first phase, including the development of an ED-specific urinary antibiogram, as well as treatment algorithms and guidelines development. And then a second phase, including the education component. Even within the education component, the first phase included predominantly education at the ED wide level, focusing mostly on resident physicians, and that was led by pharmacists, ED leadership. And then they really drilled down in phase two and did a re-education to really reiterate previous themes, as well as more one-on-one provider-specific feedback. And the outcome that they looked at was guideline concordant antibiotic prescribing. What I found interesting was that they predominantly looked at uncomplicated and complicated urinary tract infections. And what they designated as first line was nitrofurantoin for uncomplicated cystitis. And then second line was cefuroxime for those that were not eligible for the nitrofurantoin. And what they found that in the intervention groups, so after each phase, there was a progressive increase in percentage of guideline concordant antibiotic prescribing. So overall, there was a 15% increase by the end of phase two in all facilities. So they did find that there was a significant impact with that education, and they did also look at sustainable really prescribing within the guideline concordance. And they did find that having that personalized one-on-one re-education was really the most impactful. But again, if you remember the phase one, they predominantly targeted resident physicians. So you know that with resident physicians, after a few years, they do typically leave the facility, to practice elsewhere. So, having that turnover as well as continuous education, particularly in the emergency department, is really the key for appropriate antibiotic prescribing or not even needing to treat if there's no symptoms.
Go nitrofurantoin. I love to see nitrofurantoin promoted, and I'm sure your antibiogram probably looks pretty friendly towards nitrofurantoin, so I had to give it a shout out. The next article is actually one that we published as our group that I wanted to share, and it's something that you can do very easily. So 5 easy steps. Number 1, get a list of all your Vanco levels for the last month or whatever time period you want to use. Number 2, look at them to see how many of those levels were above 25. Just before you look at that list, you might think maybe 3%, maybe 4%, probably not 25%, but you don't know unless you look. So you might be surprised at how many of your levels are above 25. Now, levels above 25 can be for a number of different reasons, but one of them can be because of acute kidney injury. So look at your levels above 25, those cases, and see if they had AKI. Then if they had AKI, see if they were dosed off protocol. And at that point, you're saying, this patient got vancomycin, they had a high level, and we dosed them wrong, or we monitored them wrong, which means that you maybe contributed to this unfortunate outcome. And then act on those opportunities. Repeat this every month, and then monitor how it goes over time. Vancomycin IV is a hugely important antibiotic in the antimicrobial stewardship space and just everywhere in general. You really can't get away from it. And this intervention is not just about what can we do about high vancomycin levels. And of course, this is not perfect methodology, but you will find opportunities by having these conversations, by digging into these cases, and it'll enable you to have more conversations with nursing, with lab, with physicians, and you can improve your vancomycin use, and you can start to maybe discourage vancomycin and get it away from it to use more Dapto, more linezolid, or more Bactrim, or just DC it altogether, maybe using MRSA NAIRS to stop using Vanco. But this helps kind of talk about the topic more. And this is a very, very easy monitor to do. I can do it in about like 20 minutes for a fairly large hospital. So it doesn't have to be a lot of work. Okay, the next one is impact of clinical pharmacist discharge prescription review on the appropriateness of antibiotic therapy, a retrospective comparison. My computer, just a side note, is starting to make some noise. And if I disappear, I just want to apologize before I possibly disappear. I don't think it's going to happen, but just in case, I definitely hope it doesn't happen. But going back to this, impact clinical pharmacist discharge. So when a pharmacist is involved in discharge, do we make better decisions? Do we cause antibiotics to be used better? This is an observational study, included 150 cases, and appropriateness with a pharmacist was 83% versus without a pharmacist was 54%. So that improvement seems great to me. Some of the questions I might ponder is, where can I get my improvements? Which drug are we talking about? Are we talking about drugs that have a significant impact on that patient's outcome? Or is it really not that big of a deal in terms of the interventions I can make? I would argue that every intervention is impactful, but these are some of the questions I would ask. Now, they found that UTI and pneumonia drove a lot of those decisions. And from a regulatory perspective, we need to focus and have guidelines that are available for common infectious diseases, and that's per the regulatory guidelines in the United States, at least. So if we can make more interventions for UTI and pneumonia, I think that's a great thing and a great opportunity for antimicrobial stewardship that aligns with regulatory needs and aligns with my patients' needs. And through that education over time, hopefully we can improve care. But also, you don't need to have an infectious diseases pharmacist to do this type of work. You can train your internal medicine pharmacist or another other pharmacist. So that's one positive here, where you don't necessarily always have to have your ID pharmacist doing things. Also, a transitions of care pharmacist would be really good at this type of activity. Now, antibiotic stewardship to reduce inappropriate antibiotic prescribing in an integrated academic health system and urgent care clinics is next. This article I thought was really cool because, cutting to the chase here, they found that they could reduce antibiotic prescribing while increasing patient satisfaction, which is not something that you expect in the outpatient environment. You know, one of the conversations I've had a lot over the years with people about is how folks feel the need to prescribe antibiotics because they fear that they will get a poor patient satisfaction score since the patients they're demanding azithromycin or whatever, what have you. And so I think this is a really, really important topic. And that's why this article is nice, because if you go and you talk to a physician and that's one of the barriers that they're bringing to you and saying, this is why I can't get past it, you can say, hey, you know, there is evidence that you can have a stewardship activity implemented and not impact patient satisfaction negatively. So they looked at antibiotic prescribing measured before and after these ASP activities. And again, it focused on urgent care clinics. So the external validity to like an emergency department may not be there, but oftentimes urgent cares and ERs do have a lot in common. But the proof that antibiotics don't improve patient satisfaction, I thought was a really meaningful finding here. This article looked at improving antibiotic use for sinusitis and URI, or upper respiratory tract infections, using a virtual visit antibiotic stewardship initiative. So this before and after study looking at ARIE visits, they found that it led to better antibiotic choices and fewer antibiotic days. Now, one of the things that I really like about outpatient stewardship is this topic of how many days of therapy do I need? And we know that shorter durations, when appropriate, can be better for our patients, right? Because why take medications you don't need? You're going to increase risk with no risk of benefit. Taking the shortest course then the shortest course with the effective dose is the way to go. And if we give people 14 days of therapy when they need 10 days of therapy, you know, we're giving them 4 extra pills really for no reason. And when we put antibiotics into the community, we know that folks, you know, they feel better, they stop their antibiotics, and then they put it on their shelf in their kitchen or in their you know, in a closet, and then they have them sitting there for years and years and years. And this is supposed to be a joke because, you know, no one is signing a sworn statement saying they promise not to share their leftover antibiotics with their either auntie or their uncle in 7 years when they get the sniffles. And I definitely don't want to see people taking Cipro that's expired and been sitting in a closet for a case of the sniffles. So getting the right duration of antibiotics to our patients, I think, is a really important topic in the community. And it's low-hanging fruit for antimicrobial stewardships that are working in the outpatient environment. Now, this, I believe, is the last article we're going to go over, and it's the impact of advanced pharmacy practice pharmacists on culture response programs in the emergency department. This is a pretty hot topic in regards to patients that come into the hospital, they get a culture, or they come into a care environment, they get a culture, and then they get discharged. Here, we're talking about the ER. Now the culture comes back positive, and what do you do with it? And who's handling that culture? Because the physician who saw the patient is probably not going to be available at that time when the data comes back. So many times there's nurses or other mid-level providers that are engaged with that workflow. And sometimes it's the provider that happens to just be there that day. This was a quasi-experimental pre-post study assessing the impact of the pharmacist with independent prescribing authority. I think that's important to highlight because not every site, actually, I would say very few sites will have pharmacists with independent prescribing authority and their involvement with the culture response. So time from culture review to intervention decreased by about 5 hours by having the pharmacist involved. And there were more interventions when the pharmacist was involved as compared to the nurses. So one of my take homes was that antimicrobial stewardship programs are really primed for advancing pharmacy practice roles. Here you have a pharmacist with prescribing authority who is engaging in the ED area, and we need to advance pharmacy practice when we can. And if infectious diseases or antimicrobial stewardship can be a way that we can start to push that path forward, it can really help us in other ways beyond just the area of infectious diseases. And so I think it's worth considering that. And this is a great opportunity if it's something that would be of interest for your site. So in closing, we wanted to leave some time for questions and Q&A if possible. Antimicrobial stewardship opportunities are plentiful. Like you just have to look left, look right, look up, look down. They're everywhere. The outpatient, inpatient, focused on broad spectrum, gram-neg, anti-gram-negative, gram-positive, working with lab quality, your ICU staff, nurses. The list just goes on and on and on. So the opportunities are plentiful. So what are you going to do? And that's really the big question I think we all kind of face on a daily basis. And then what does the most impactful stewardship program do? They tailor their goals and they tailor their actions to the needs of the organization. And that helps them become stronger stewardship programs because they align with other departments within the institution, but also they're hitting those, they're really helping their patients at the same time, which is, of course, always the number one goal. And then finally, I would really want to just encourage everyone to try to publish your experience. We need more literature. We see the guidelines don't have a lot of really strong recommendations because the literature, is still emerging and stewardship is still a pretty new field. So just please, please, please think about publishing your experience, working with people to publish larger data sets and share your ideas, share your innovation, and don't be afraid to borrow other people's ideas because we need to put our heads together in order to address this major problem of antimicrobial resistance across the world. So with that, I will kind of, I guess, welcome the host to come back on, and we're happy to answer or to have any discussion about questions.
First of all, thank you so much, Dr. Gauthier and Dr. Thomas. Those were lovely choice of papers. I think some interesting papers out of that, like really good ones. So what I felt was like some major thing where you could look at is ED, the papers which came out of ED, but that's the place where the transition of care happens into the hospital. And if you get that right at that point over there, it's almost half the job done because a lot of things could be done through ED and quite a lot of interesting papers where you could use the workforces around you, rapid diagnostics. Again, if you're compliant to your level, like the vancomycin papers, like if you're compliant and if it's causing any collateral damage, if the levels go high, quite interesting. And the burnout paper in ID that I was thinking like very interesting one fact because you always think at some stage when you're practicing that, okay, how do I reach up to so many cultures, or how can I optimize care for all those patients? But like, what do you do for this? Like, those are some really good papers. I felt like good choice, different set of papers which covered a variety of different aspects in stewardship, which also even touching patients and mentioning that don't use their antibiotics for the aunties and if they go on to so those are lovely. So I have few questions here, so let's go one by one. So the first question is how to approach in implementing an antimicrobial stewardship program in a low middle income country or a resource limited setting where you may not have a clinical microbiologist or ID physician. It could be an ID interested physician running the program or a pharmacist running the program. So like what would be your advice on implementing the stewardship program in this kind of setting?
Yeah, I think that's a really important question and one that continues to be asked by many people. And again, an opportunity for us to share our wisdom and our experience as we go through that process and as the world changes. But, identifying the priorities is one of the top things to do. And there are activities that maybe you don't need to do it as formally, but do a risk assessment and say, what are my number one items that are a problem or a challenge? Is it vancomycin? Is it zosyn? Is it antibiotic initiation or de-escalation? Is it your ICU? And then get those top things that are really the challenging areas, and consider also what data do you have access to, if any. So if you have some data, it's going to strengthen your ability to change people's minds. Because, for example, when you're working with physicians, it's really not good to go and tell them what to do. It's better to go and show them data and let them make a decision, because they're smart and they will understand like what the right decision is based on the data. So I do think there has to be some kind of effort to look at what data is locally available and use that as you implement your stewardship program. But you also have to think what is functional and feasible at the same time. So you can't set goals that are just going to be impossible to complete. So writing down, what are the items that are particularly problematic, and having that list, and then see if you can kind of take 2 or 3 of those and combine them. So maybe fluoroquinolones and urinary tract infection and the ED are all on your list. Well, then try to design an intervention or a program that can hit all 3 of those at the same time, because you're educating the ED and you're changing the way something is prescribed. And you have to accept your limitations. If you don't have microbiology data at X number of hours, you can't implement a program circling around having information at that number of hours. But what can you do? So try to attack your program, your problem from different areas. I think trial and error is really important. And then also just being open about, you need to work as a team. Now, as I've interviewed a lot of people doing stewardship around the world for my website, and the theme continuously is never try to like win a battle at the expense of the war. So relationships and relationship building is extremely, extremely important. And thinking long-term with your endeavors is very important. So, laying the groundwork, getting an idea, revisiting your ideas, trying to use your data, working with partners, building relationships. Those are the keys to success, and then trying to employ that locally. Those are my thoughts, at least.
I think those are really useful thoughts. So, in a resource limited setting like in India, a low middle income country, the problem would always be the same, like the difficulty in de-escalating, or
Yeah.
the treatment goes on and you still have resistance. But how do you control the use of antibiotics, and how do you approach a physician? So, as you've mentioned, approaching them with literature and working as a team together would definitely help. And I think these are really useful tips. I have the next question. It is again, it's again the how to utilize the pharmacy student workforce for stewardship. Again, because this stewardship and infectious disease is not there in the current pharmacy curriculum in India. So, but with these limitations, how can you utilize the student workforce? Because most of these hospitals would have a lot of students rounding with physicians, because there would be limited number of clinical pharmacists in the hospital, but they would have a very good student workforce with these physicians. How can that be utilized for stewardship activities in the hospital, like at a student level?
Yeah, I think, one of the major focuses with students to never lose is they're there to learn. So we don't want to give them like tasks that don't involve them learning and advancing their knowledge. So that's always an important piece of that consideration when working with students on any project. But I think that the key to success in this area is structure. So having a checklist for IV to PO, and then having a functional way to generate the medications that you want to be evaluated for IV to PO, and having that student go through that checklist, and having a workflow so that when they find that the checklist shows that someone could probably be changed, they're able to escalate it to the appropriate person. And having that consistent approach every single time of, we look at these drugs, these are the things that we're looking for, renal dosing. If it's de-escalation, that might be a little bit complicated for a student, but starting off fundamental and trying to set up programs that can stand the test of time, right? It's really easy to get ahead of yourself. And with some of these studies that we talked about today, and, I think through all of our experience, we see that longevity is a big challenge. So having that structure to the program is something that I think is just really important. And through checklists and workflows is something else that you have to really pay attention to in stewardship. And, the operational component of healthcare has a huge impact on the antibiotic decisions that are made and why those antibiotic decisions are made. So how those antibiotic decisions are made is kind of like the social component, and I really don't want to use Vanco, and I have all these feelings about it, so I'm going to make a decision about it. But what really kind of forces the issue sometimes is the workflow about the availability of the drug. And so you need to consider operations as you consider these types of initiatives. I hope that makes sense.
Yes, I think definitely. I think the low-hanging fruits would be the ones the students could start off with, as you mentioned. If you put that on a checklist form, students could go through that, and obviously they could discuss with their preceptors or the physicians who they're rounding with, and for sure the checklist and starting with low-hanging fruits would definitely help. Thank you so much. The next question is, how do you document the stewardship data and like present it to hospital administration or leadership and or to national authorities? So as a clinical pharmacist or a student, if you're doing this, what would be the highlight? Because their perspective of thinking would be completely different from a clinician's point of view, or completely different. So how would you present the stewardship data to the administration and leadership, or to national authorities if you have to change something at a stewardship level or program?
Yeah, that's a great question. And you got to look at your audience, and your audience changes. So the same presentation might change as you go from audience A to audience B to audience C. So one audience might need a very technical presentation about what you did, how you did it, and then so they can understand what the data means. So having those methods are important. But if you're presenting information to a high level group, like a C-suite level, or people that aren't familiar with some of the concepts, they're not going to learn the concepts in a presentation. And people generally will not walk away with remembering what you said, but they will remember how you made them feel. And telling stories, I think, is a really, really important component to communicating the importance of antimicrobial stewardship and why people should care about it. So talking about the topic and letting them know about the topic and using a story, especially a local relevant story, to help them understand why it's important, I think is a really good strategy for communicating to high-level leaders about the stewardship program. Now, as you establish a relationship and you kind of move that down the line, you can then start to bring in more technical information possibly, but really you want them to walk away from that meeting thinking and reflecting about what you told them and using real world actual examples. So talking about your carbapenem resistant organisms and maybe a really tough case that came about. And I would pull on those heartstrings because communication is not just here are the numbers, it's why does it matter? And stories help us communicate why it matters.
True. I think the audience you need to present to is important, and you have to change it accordingly. And again, to make it more, the problem should be identified when you present as well. I think these are a few good points when you present to leadership or people who are not practicing but are looking to more in terms of resources and monetary benefits and like other quality issues in terms of hospital patients and things like that. So I think one last question would be on publishing data from India. So there are only limited papers published from clinical pharmacy from India. So how do you think like this could be done at a resource limited setting where you have to show the data? Again, could we replicate data from other papers from based on the hospital experience, or should that be unique or like a kind of setting up a program? Because only quite very limited literature is published from like a stewardship program from India, and there are quite a lot of hope that we could do it in future, but again, resource limitations and a lot of challenges are there. So how is it possible? That is the question, to publish data.
Yeah, and I really appreciate that question, especially as I'm here, like, publish your work because we need more work. And I'm always going to say that because, that's just the nature of the game. But in reality, I think teamwork, that's how you do it, right? You figure out a system, a strategy where you can move your project from implementation into publication. And that involves working with other people, a student, a resident, and as they go through their training, getting them hooked into the project so that they understand what it is and let them drive it and let them take ownership of it. And then you're training the future stewards at the same time. I think that's one of the ways. And then also through societies, like this group and the Society of Infectious Diseases, pharmacists and others, I think those are especially important points for enabling that work and the training in that space. And then also participating in meetings that exist and just sharing an abstract. I think there's a lot of value there. Just, if we look at it and say, oh, we have to do this 3,000 word publication, it's daunting. It's ridiculously daunting, but a 250 word abstract may be reasonable. So, you can start there. It's totally fine.
True. Completely agree, because we have quite a lot of pharmacy audience in our group here, and quite a lot of them could pick up topics in stewardship and infectious diseases. Simple, like they definitely would need a person to guide them through the publication process. But the first step would always be sending an abstract, presenting it in a conference, and on a later stage, like as the paper comes to a completion, make sure that you publish it. I think that's the way forward. I think these are the few questions we had, and it's time to wind up. Thank you so much once again on behalf of the whole team and our viewers, to Dr. Gauthier and Dr. Thomas. It was lovely having you. Amazing set of papers, a good interactive question answer session as well. Thank you so much, and have a lovely rest of the day. Thank you.
Thank you so much again for the opportunity.